Good morning, everyone. Sorry.
I will be speaking on Ewing sarcoma today, and tomorrow's class will be a case presentation on Ewing sarcoma. Following topics, the headings will be covered: epidemiology, classification, diagnosis and workup, staging, prognostic factors, treatment, and outcomes. Epidemiology, it is second most common childhood primary bone tumor, around 3% of all the pediatric cancers. Incidence is around 3 cases per 1 million in US. It is less in Asians because of the polymorphism of the EGR2 gene on the loci 10q21, which helps in the functioning of the translocation of the Ewing sarcoma family group. Males are more common compared to females, and it is more common in the age of 5 to 25 years with a median age of 15 years. Ewing sarcoma is a tumor comprises a family from which ranges from Ewing sarcoma, which is least differentiated, to a well differentiated PNET or a chest wall tumor of Eskens tumor, and in between there are a typical Ewing sarcoma. Based on the histology, there is no difference in the outcome, whether it is Ewing sarcoma or PNET. Sites, the most common sites is more in the axial skeleton compared to the appendicular skeleton, and more in the axial skeleton in the pelvis, rather than in the appendicular skeleton it is more common in the femur. Extraosseous, which comprises less than 1%, have a better prognosis. More commonly in the extraosseous, it is found in the trunk compared to extremity, followed by head and neck and retroperitoneal region. Skin tumor have an even I saw yesterday when I was reading that skin tumor, there is Ewing sarcoma can occur in the skin with outcomes of more than 90%, 5-year survival of more than 90%. So this is the pictorial presentation of the most common site of the pelvis and the femur. Clinical presentation, most common presentation is pain, which comes and goes, and more often patient says that it increases at night. There is increase with exercise. Local swelling or mass effect in the mid shaft region, distinct soft tissue mass seen in 1/3 of the cases. Constitutional symptoms or signs: low-grade fever, weight loss, or malaise is seen in around 10% of the cases. If there are constitutional symptoms, then most likely patient has metastasis. Median interval from symptoms to time of reporting is around 2 to 5 months, and neurological symptoms may be there in around 15% of the patients due to compression of the nerves. Metastasis at diagnosis is found in around 20 to 25% of the patients. However, if there is role of giving neoadjuvant chemotherapy in these patients before starting before planning a localized treatment. Metastasis more commonly occurs due to hematogenous route and direct route. The lymph node involvement is less common. Lymph node involvement is directly classified as T4 stage 4 disease. More commonly, metastases occur in the lung, followed by bones, followed by bone marrow, and then the other sites of the. How do we approach a patient who has Ewing sarcoma? First is a benign lesion or a malignant lesion. If there are chances that it could be a malignant lesion, then a biopsy with routine histology and IHC. In rare cases, cytogenetics may be required, molecular testings. Then lab report like CBC, RFT, LFT, including LDH. The higher the LDH, more chances that it would be a metastatic disease, and it also indicates a poor prognosis. Bone marrow aspiration biopsy, PET CT scan in other patients. It is up to the tune of 4.8% in newly diagnosed patients, and in 17% of the patients with metastatic, the bone marrow would be involved. With the onset of PET CT scan, bone marrow biopsy is not been done now. Imaging, plain X-ray, CT, or MRI of the local to characterize the local extent. Bone scan and PET or a PET scan to see involvement of the other bone, and because most common site is lung, then CT chest if PET scan is not done. Fitness for therapy would be DTPA, GFR scan and 2D echo. So what do we see in biopsy? In biopsy, you will see it is a differential diagnosis of a small round blue cell tumor, where we can see homogeneously small cells with high nuclear into cellular ratio, uniform round nuclei that contains evenly distributed chromatin, and cytoplasm is very scant, weakly eosinophilic, and you can see classic homerite rosettes in this picture. Molecular pathology. So, Ewing sarcoma family tumor translocation, which is commonly referred, is found. Chromosome 22 has Ewing sarcoma gene, which is translocated to chromosome, and chromosome 11 has FLI gene, that is friend of leukemia. It most commonly fusion in 95% of the patient, you will see either fusion of EWS with FLI1, but other non-translocated EWSR1 and non-EFT translocation are also found. Other chromosomal alterations that can be found are gain of chromosome 2, 5, 8, 9, 12, and 15, non-reciprocal translocation of T1 and 16. The amplification of 1 and 16 are found in most of the childhood tumors. You will see in other neuroblastoma and other tumors also. A deletion of short arm of chromosome 6, trisomy 20, and trisomy 8. The fusion of what is the transcript of 1122 hardly matters in the outcome. It is the pathway involves amplification of IGFR1 pathway, leading to overactivation of the IGFR1 pathway, and now antibodies against IGFR1 is being developed and in early stages of clinical development. Uncommon translocations in 5% of the patient could be translocation 21 to 22, translocation 11 22, 17 22, and translocation 2 22. Now, WHO last year has classified Ewing sarcoma in the Ewing sarcoma family 3 other type of tumors. That is where patients who do not have classical EWSR1 and non-ETS fusion undifferentiated small round cell tumor, CIC rearranged undifferentiated small round cell sarcoma, and sarcoma with BCOR gene alteration. I will come to this 3 subset later on. So first one is EWSR1 non-ETS fusion. This sarcoma with EWSR1 or NFATC2 and FUS NFATC2 fusion, they typically arise in long bones with male predominance. These are based on 30 patients incidents that this have been characterized. Appear to be poorly response to chemotherapy. Presence with either of this should not be taken as an indicator of malignancy, but rather needs to be interpreted in light of clinical settings, because they can be found in even benign bone lesions, these translocations. Sarcoma with EWSR1 and PATZ1 fusion, it is found common in both gender, same with in male and female, has truncal more commonly in the trunk, particularly in the chest, and it is found in the elderly around 40 to 50 years of age. What are about BCOR rearranged sarcoma? BCOR CCNB accounts for around 5% of EWSR1 negative sarcomas. More commonly affect younger males around 18 years of age, and it comes in the bones of the pelvis and extremities, and mets are present in approximately 30, higher chances of metastasis. More commonly, it has BCOR CCNB3 rearrangement, and less commonly BCOR MAML3 arrangement. BCOR internal tandem duplication can be involved, also be found in some patients. What about CIC gene alteration? CIC DUX4 rearrangement is most commonly affect young adults between age of 21 to 40 years. More commonly affect males, usually originates from the soft tissue of the trunk and extremities. CIC rearranged sarcoma most commonly have CIC gene, which is on the loci 19q13.1 fusion with the DUX4 gene, which is on 4q or on 10q, thereby leading to translocation of 419 or 1019. CIC DUX rearrangement express, how can we identify on IHC, is they express more of WT1 in ETV4 in contrast to Ewing sarcoma and BCOR rearranged sarcoma, making IHC more useful in patients to distinguish whether it is CIC DUX rearranged Ewing sarcoma. To confirm your Ewing sarcoma, we can do a FISH by a break apart probe. Break apart meaning EWS1 is EWSR1 is most commonly there's break point in that, leading to breakage from the green signal would not be, the signals would not be continuous, and you can see break apart signals in this cell where two different red and pink are seen separately and not combined as seen in the normal cell. However, fish is also not confirmatory because it may be positive in other differential diagnosis like desmosplastic small round cell tumor, clear cell sarcoma, extraskeletal myxoid chondrosarcoma, and myxoid liposarcoma. So can we detect the RT-PCR in blood? Yes, in a small subset of patients. In last 3 years back, this publication has been developed, has been published, and it shows that you can detect EWSR in the peripheral blood up to the tune of 80% of the patient. Again, this study was also in 30 to 40 patients only. X-ray. X-ray, you can see classic X-ray on the left side of your screen with onion peel appearance that we have been studying since MBBS days. It may more commonly involves the diaphysis of the bones, and pathological fracture can also be found around 10 to 15% of the patients. MRI is useful to see the intraosseous extension, the extra soft tissue extension to planning the local surgery and radiotherapy, and it also helps in seeing the intramedullary extent. FDG PET scan has increasing role in Ewing sarcoma. It identifies bone metastasis. It helps in prognosticating the outcome. The SUV uptake correlates with the outcome. Now, with the onset of commonly using PET CT scan, bone marrow biopsy has been eliminated using bone marrow biopsy, because bone marrow involvement sensitivity is around 100% with 96% specificity and positive predictive value of 75% with 100% negative predictive value of PET CT scan. So it is bone marrow biopsy is not needed now. Only you will miss around 0.3% of the patients if you don't do a bone marrow biopsy and rely only on PET CT scan. So what are the prognostic factors in Ewing sarcoma? Distal tumors do better than the proximal tumor, than the central sites, because central sites surgery is not feasible easily. Extraskeletal primary tumors have a better prognosis. As I told you, even skin has 90% 5 years outcome compared to the skeletal metastasis. Volume of around 100 to 200 ml have been arbitrarily assigned in various trials, and those who have volume of less than 100 or 200 ml or have a diameter less than 8 centimeter do better than compared to the larger tumors. Children do better than the older population, more than 50 years of compared to more than 15 years of age. Females do better than males. Those with increased LDH have associated with inferior prognosis because of the higher tumor burden. Metastasis, those who have metastasis at baseline do worse compared to non-metastatic tumor. In metastasis also, those who have lung metastasis do better than the extrapulmonary metastatic site, even compared to those who have without regional lymph nodes. Those who have pathological fracture associated, they do worse compared to those with non-pathological fracture. As we saw, there are other chromosomal alterations also found in Ewing sarcoma. Do they affect the prognostic? Not much, but gain of chromosome 1 and or deletion of chromosome 16 have been associated with inferior outcomes. Those who have circulating DNA visible in the peripheral blood, so this 94 patient cohort showed that those who have detectable have inferior EFS and OS. Those who have detectable RT-PCR in the bone marrow have, in a small retrospective study, it showed that they have poor prognosis, but in the larger cohort, there was no difference in EFS and OS. Genetic alteration that can be found are TP53 mutation in around 6 to 7% of the patients, CDKN2A deletion in around 12 to 22%, STAC2 mutation in around 15 to 20%. Individual mutations of all this are not associated with difference in OS, but in a cohort when 9 patients had both mutation of STAC2 and P53, they did worse significant OS, that is only less than 20% at 4 years, compared to the average that we say of more than 70%. So if there are 2 alterations, then yes, you can predict inferior OS, but individual have not shown to have poor prognosis. Commonly P53 in solid tumors, we say it has poor prognosis, but here it did not show, and it is found in 6 to 7% of the patients. Other prognostic factors that we can see is response to initial chemotherapy, whether there was minimal or no residual disease and after in the local therapy, and PET CT scan has correlated with good outcome response on PET CT scan. Which have not shown any prognostic significance are the degree of neural differentiation and the molecular pathology, whether there is translocation or not associated with the translocation of EWS, or in what breakpoint region there was the translocation, has not shown any significance. So site we can see extreme in this JCO article of 2000 that those who have extremity have Ewing sarcoma of the extremity have 5-year survival around 67% compared to those 50% in those with axial skeleton. Obviously, because of the difficulty in treating and late diagnosis in the axial skeleton compared to the extremity, where the swelling can easily visible and diagnosed early. Those who have localized, they have 5-year survival of around 55% compared to 21% those who had metastasis. Site of metastasis, we can see that those who had lung did better compared to bone, and more better compared to those who had both lung and bone involvement. Response to therapy commonly used is Hoover's grading system, where we can see those who have 100% necrosis, their 5-year EFS is around 84%, which is almost equivalent to those who have necrosis of 90 to 99%, same around 84%. So we commonly see whether the necrosis is more than 90% or less than 90%. Those who have less than 90%, we can see that the EFS is less than 37% in those patients who have poor necrosis. So Hoover's grading system is commonly used. So let's come to the treatment part, which is very much complicated. Most of the resident don't understand initially, but after using it, they do understand. Let's see how it evolved over a period of time. So you give neoadjuvant chemotherapy for 2 reasons. First is to as a prophylaxis to eradicate the micrometastasis, because we saw that around 80 to 90% have occult metastasis, and compared to 25% who present with frank metastasis. And second reason is to facilitate conservative surgery. So for 2 reasons, you give 6 to 15 weeks of neoadjuvant therapy. More than 15 weeks in retrospective analysis have shown worse OS compared to those who have received around 6 to 15 weeks of neoadjuvant therapy. So 6 to 15 weeks, you can give some neoadjuvant therapy so that surgery can be planned adequately and to remove the micrometastasis. Then local therapy is to be done around 6 to 15 weeks from the onset of therapy, which can be surgery or radiotherapy or both of them. And then maintenance therapy is to be given. That will come how much? Okay, so local therapy can be either be surgery or radiation or surgery plus radiation. Nobody has compared the 2 of them. So surgery plays an integral role in local treatment. Initially, amputation was treatment of choice. Now, limb-sparing surgeries can be possible in 70 to 80% of the patient. What we have to keep in mind is the margins in bone around 1 centimeter margin, but preferably 2 to 5 centimeters required. If you are giving radiation, then around 2 centimeter of margin on either side is kept compared to the pre-planning, pre-NSCT scan. And soft tissue margin around 5 millimeters and facial planes around 2 millimeters. So advantages of surgery compared to RT is avoid the secondary RT induced sarcoma. You can assess the degree of necrosis and thereby estimate the prognosis. And children, it is less morbid than RT because of the growing bone in the children. But what are the disadvantages of surgery? You will require a prosthesis, and there are high chances of prosthesis infection, bone healing difficulties, and fracture can occur in those prosthesis. So can we use radiation? Radiation can be used. Nobody has compared whether surgery is better or radiation is better prospectively. People have used both of them in margin positive and seen that if margin positive resection, if you give RT also, the local failure rates decrease. And local failure rates with definitive RT where surgery cannot be done was around 26% in the combined analysis of CSS 8186 and EICSS 92 trials of 1,000 patients. So there is no difference whether you do surgery or radiation, or but obviously if you do both, there is less chances of local recurrence. So radiation can either be given definitive when the surgery is not feasible, such as sites at pelvis where surgery is very difficult. Definitive radiation around 55 gray is conventionally used. There was a trial in TMH where they escalated the dose gradually over a period of time and modulated the dose. as per the response to therapy up to 70 gray, but in the accrual cannot be completed. And post-operative RT used to be given for poor histological response, but now it is query because there is no response to chemotherapy, less response to chemotherapy. Even radiotherapy, they are not radiotherapy sensitive, but obviously prospective evidence is not available. So now we use cautiously for poor histological reference response, but we do commonly use for those with R1 or R2 resection, and those who have higher volume at more than 200 ml of volume at baseline, or soft tissue involvement. Those are some soft indicators where we decide regarding adjuvant RT. So local therapy should also be used for the metastatic sites. Here we can see that patients who in prospectively done Ewings 99 trial, patient who underwent metastatictomy of the lung had an event-free survival of 25%, compared to who do not received any lung therapy, which had only 13% overall survival. But those who underwent both metastatictomy and whole lung irradiation, they had overall survival of 47% at 3 years. So as more and more local therapy you use, the survival increases. These are the other trials which show the benefit, most of them retrospective, which show the benefit of local therapy for lung. Even for bone metastatic site, you can increase the overall survival by giving palliative RT or curative RT to the metastatic sites of the bones also. Around 45 gray of 45 to 50 gray of RT is given to the site of metastasis of the bones. So how did chemotherapy evolve over a period of time, and why is it so complex? So, in 1960s, patients were given cyclophosphamide, and they around 3/4 of them showed response. So cyclophosphamide was found to be an active drug. In 1966, Jackie et al. Tried nitrogen mustard, and they found response in all 3 of the patients. Later on, they combined it with RT because of Mr. Ewings described that it is very RT sensitive disease, and they saw that sustained response in all 5 patients when they were combined with cyclophosphamide, vincristine, and RT. Later on, doxorubicin when added, that VAC showed more response compared to either of the single agent drug. So VAC becomes standard of care. Then came MSKCC trial, which showed that can we combine VAC with RT? Yes, those who received BAC with doxorubicin did better than those who received only VAC. VAC was actinomycin. Here D is doxorubicin. So later, further studies were done on the backbone of VAC. VAC individually showed in each drug individually showed response in Ewing sarcoma, so they were combined. The VAC showed an FIRE RFS around 24%. Later on, doxorubicin was added in 3-arm study. Doxorubicin was added and it showed FIRE EFS around 60%, increase from 24%. And though a third arm was VAC with RT, and they also showed FIRE's EFS of around 44%, better than VAC, but inferior to VAC with doxorubicin. So VAC with doxorubicin becomes standard of care after this IESS1 trial. Then came another trial. Should we give it at low doses weekly, or should we give it high doses and intermittently at 3 weekly? So this IESS2 trial showed that giving them every 3 weekly is better than, because you give more amount of dose, is better than giving them at weekly doses. So with FIRE, our relapse-free survival of around 73% in the 3 weekly arm compared to 56%. So intensity of the dose does matter. Then came another trial where because people found that ifosfamide and etoposide are also very much active drugs in Ewing sarcoma. So they randomized 518 patients, including 120 metastatic patients, into the 2 arms, VACD with alternating with ifosfamide on VACD alone. And they found that in the metastatic subgroup, there was no benefit of adding ifosfamide. The FIRE EFS was same in both the arms, around 22%, and FIRE OS was same around 35% in both the arms. But in the non-metastatic subgroup, there was significant benefit found, that FIRE EFS increased from 54% to 69%, 15% benefit by adding 2 drugs, ifos and etoposide. So this becomes standard of care to combine.
Good morning. How are you? Are you there?
These are the Kaplan-Meier curves of the previous of the trials that we were seeing. We can see that the non-metastatic subgroup had better with addition of ifositopacide compared to those who did not receive ifositopacide, and the metastatic subgroup are lying over each other, whether you give back or IE, back with IE alternatively. Then came an interesting study. Can we increase, should we increase the dose further of ifosfamide and cyclophosphamide? So you can see the difference I have boxed here in the red, that they increased the dose of cyclophosphamide from 1200 milligram per meter square that we use conventionally to 2100 milligram per meter square, and ifosfamide that we use 1.8 grams to 2.4 grams for 5 days. And they found there was no benefit of increasing the dose of ifosfamide and cyclophosphamide. The 5-year EFS was same, 70% to and 72%. So further increasing dose did not help. So can reduction of the time period of giving the dose matter? So this another COG study was done, which used 4 cycles of VCR, VAC, and ifositopacide that we use now, but every 2 weekly, and followed by local surgery, and then 2 weekly of 4 cycles of VAC and ifositopacide, and compared to the conventional 3 weekly regimen. And they found that giving it 2 weekly, their 5-year event-free survival increased from 65% to 73%. So these became standard of care, that giving the same dose but increased frequency at every 2 weekly is more better than 3 weekly. So further studies tried, can we replace ifosfamide with cyclophosphamide? Why? Because long-term use of ifosfamide was causing renal toxicities. So here patients with good local response were given 6 cycles of wide initially, with followed by 1 cycle of VAI, and then randomized to either VAI or changing it to cyclophosphamide. And they found that 5-year EFS was almost the same. So we can change further ifosfamide and need not continue ifosfamide for all these 14 cycles as alternate, that is 7 cycles of VIE. We can change it to cyclophosphamide. This is what we could make out from this trial. And thereby reducing the renal toxicities from 13% in ifosfamide arms to only 16%. But however, cyclophosphamide caused more of thrombocytopenia. It was 35% in the ifosfamide arm and 45% in the cyclophosphamide arm. Now let's come to whether bone marrow transplant. As we saw that these patients are very much sensitive to chemotherapy, and increasing the intensity of chemotherapy is helping them. Can we help them further, improve the survival further by adding high dose chemotherapy followed by stem cell rescue with autologous stem cell transplant? So this was the first trial where you can see they had randomized into they had classified into 3 arms. We will see about the and the metastatic subgroup. It did not show benefit, but in this selected population, as we can see here, age less than 50 years, those who have localized disease, biopsy proven, and had high risk, that is residual viable cells of more than 90% after initial induction chemotherapy, pre-treatment volume of more than 200 ml, treated with radical RT, and they had less than 50% reduction radiologically, and those who have not received RT to the spinal cord or to large intestinal volume were randomized to 2 arms, that is continuation of VAI chemotherapy versus autologous stem cell transplant with Bumel. And you can see that the 5-year event-free survival increased from 56%, 3 years event-free survival increased from 56% to 69% in the autologous stem cell transplant arm. And 3 years OS also increased from 72% to 78%. And this was maintained at the end of 8 years also, which that the survival was, there was a difference of around 9 to 10% even at the 8 years difference. Obviously, giving them autologous stem cell transplant with high dose chemotherapy was more toxic. You can see more toxicities, all sort form of toxicity and grade 3 toxicity more in the autologous stem cell transplant arm compared to the continuation of chemotherapy arm. Those who had lung mets, they did not do better with autologous stem cell transplant, and they did almost the same whether you continue chemotherapy or do autologous stem cell transplant. So the median OS of patient who continued, who had progressive disease on induction had only less than a year, but without autologous stem cell transplant was also 1 year. And but however, those who responded beautifully to initial induction chemotherapy, they did better. 3 years AFS reached to 57% of patients who had CR with initial chemotherapy. So this is how our EFT 2001 protocol has come around. We saw that giving VAC is standard. Doxorubicin has a role in induction chemotherapy, and ifositoposide has a role in increase the overall survival. So our induction combines of 2 cycles of VAC and 2 cycles of WINE, followed by maintenance has 2 cycles of VIE, and it has been the further ifosfamide has been replaced by VCD. Because doxorubicin has dose limiting toxicity, further doxorubicin is also limited, and it was replaced with dextroamycin. Now people hardly use dextroamycin because it has been shown that it is not much benefit over compared to the other active drugs of doxorubicin and vincristine and ifosfamide. But we continue to use EFT 2001 to reduce the toxicities of ifosfamide, long-term toxicity of ifosfamide, and replace it with cyclophosphamide. Let's come to how do we treat recurrent Ewings sarcoma. If there is most of the relapse occurs in less than 2 years. 80% of the relapse will occur in less than 2 years. Hardly there are relapses after 5 years. Incidence of late relapse are still noted around 13%. The overall prognosis in a recurrent Ewings is poor. 5-year OS is around 10 to 15% only. Time to recurrence is the most important indicator. If the 5-year OS is more than 30% if it recurs after 2 years, but it is less than 7% if it recurs within 2 years. Both local and distant relapse do worse than either alone, and isolated pulmonary recurrence still has better outcome because you can use lung irradiation. What chemotherapy can we use? So multiple chemotherapy regimes have been tried. Ifositoposide with or without carboplatin has shown overall response around 51% with 2 years OS around 28%. These are all based on small studies of around 30 patients and multiple retrospective studies. Gemdosi has overall response around 29%, median duration lasting only around 5 months, as in other soft tissue sarcomas. Cyclophosphamide and topotecan is an interesting regime with overall response around 44%. 1/3 of the patient went into CR and remained into CR even after 2 years. Irinotecan temozolomide has increased overall response rate, but the duration of response was not long lasted. An interesting trial was done recently and published in were presented in ASCO 2 years back, where they, because of the increase in the overall response rate with irinotecan and temozolomide, this regimen was inserted into the induction regimen of what is commonly used back and IE alternatively. With that, irinotecan and temozolomide was also added to induction regimen, but it did not show improvement in the OS at 3 years. So it is not being used in upfront setting, but it can be used in the relapse setting. A recur trial was done is being done in the relapse setting, where this 4 regimens are compared, and gemdosi and irinotecan temozolomide has been dropped from further continuation, and cyclophosphamide topotecan is being considered further because of the lower efficacy of these 2 regimes, gemdosi and irinotecan, compared to cyclophosphamide and topotecan. How do we treat the newly classified round cells, undifferentiated round cell sarcoma? So when compared, they are still treated with Ewings like regimens only because of the small number of patients belonging to this undifferentiated sarcomas. We don't have prospective data. Should we treat them differently? But when treated with the same regime, this one series of 36 patients showed that the 3 years and 5-year survival are around same as 93% and 72%. And similarly, in this another series of 26 patients. How to treat CIC gene alteration tumor? Again, they are also treated on the lines of same EFT protocol or whatever protocol is being used in the individual institutes, with 2-year and 5-year overall survival inferior to the common EFT, common Ewings sarcoma. So summary is Ewing sarcoma is a rare but aggressive tumor. The outcome of localized tumor have improved drastically over a period of time, and induction chemotherapy with curative intent is to be tried even in metastatic patients at the outset, and later on modified tailored according to the response to therapy. And high dose autologous stem cell transplant may be appropriate in very select subset of the patients. But still, main challenges remain: how do we predict who is going to recur, and how do we prevent it? And as the outcome increases, the how to reduce the long-term toxicities. For metastatic patients, the take-home message is there is no benefit of ifosfetopuside to VAC. However, still most of the institute continue to use VAC with IE if there is initial response to therapy, and there is something which we commonly follow scientific evidence, but here nobody wants to follow. Everybody still uses, if there is good initial response to VAC, then they add ifosfetopuside to the regimen, but after seeing the initial response. Thank you. I am open to taking questions. So first were that there were issue with my microphone. Later on, does prognosis change if the translocations are different? So for because 95% of the patient have translocation, the common translocation, the prognosis doesn't change. But now, as further classification, as last year I told you, WHS classified that there is which do not have the classical translocation, they do worse compared to those who have classical translocation. The rest 5%, but obviously the rest 5%, the numbers are so small that proving that prospectively is difficult. When do you suspect Ewing-like tumor? How do you treat them? So nowadays, our pathologists, based on the IHCs, try and characterize, saying that it is Ewings-like, whether there are high chances of CIC tox translocation or BCOR gene rearrangement. But we don't do translocation even now to confirm them by translocation studies. But we treat them with Ewing sarcoma, as I showed you in this 30 patients series. That outcomes is almost similar. So we treat on this same lines of Ewing sarcoma. Why do we need DTPA GFR in these patients? Because of initially ifosfamide was used very commonly in this regimen, and we saw that renal toxicities is up to the tune of 30%. So DTPA GFR was commonly used. Now we use very selectively in elderly patients, not in all the patients. Role of auto-BMT in relapsed Ewings and PNAT. The relapsed, I'm not sure, but we saw that in those who have the metastatic disease, they don't benefit. Relapse, I'm not sure. What are the cumulative doses of doxocyclophosphamide in EFT 2001, and how is it different from COG protocol? So COG protocol, this is almost similar to COG protocol. They use COG has used VAC and IE. After 6 cycles of VAC, they have omitted doxorubicin. Here we have omitted doxorubicin after 4 cycles only. We use 5 cycles of doxorubicin. Rest of them are VCD. And ifosfamide etoposide is being continued in there for 7 cycles. We use ifosfetopuside for only 4 cycles, and then it is being replaced by VCD, the dactinomycin.
Prabhat, just correct, Jaya here. Can I? So I think also the CG protocol had, a higher dose of cyclophosphamide. Like we use, I think 600 milligram per meter square, whereas there the dose of cyclophosphamide, I think is close to 1.2. You can correct. So
yes, ma'am.
So there, whether
for 1.2 for 1 day. Sorry.
So for day 1, so like overall, is our total dose of cyclophosphamide less than the COG, because there all the cycles of VAC have a higher dose of cyclophosphamide. IFOS dose is same except for the VIE, and we are using, I think, weekly VCR also, which sometimes in elderly patients has a lot of neuropathy. So,
Ma'am, Lingaraj here.
Mm-hmm.
Ma'am, what
Yeah.
is the so why we reduce the dose of cyclophosphamide? Because doxorubicin, okay, of cardiotoxicity, because the cumulative dose in COG is I think around close to 400. But about cyclophosphamide and
This I
ifosfamide,
think.
why
Yeah.
we
So I
reduce
don't.
and replace with actinomycin?
No, no. I think, see, the actinomycin D is replacing doxorubicin. It is not replacing cyclo and ifos. It is only after you reach 375 milligram per meter square of doxo that they have switched to actinomycin D. And the same is true for, even the COG. There also the protocol after 375 of doxo, they have switched to actinomycin D. Now, with regards to, the dose of cyclophosphamide, I think that was what the previous, I think the 2001 was. That I don't know the answer to. And whether, I think, hmm
Yeah, the cumulative dose of cyclophosphamide then will be less in our protocol, right? The total
Prabhat can check.
cumulative dose of cyclo.
Yeah, the total cumulative dose of cyclophosphamide, I think, is less, but I need to check that. Prabhat, maybe you can let us.
The total cumulative dose would be 10 cycles, 600 milligram per meter square of 10 cycles.
6
6,000.
milligrams.
Yeah, so
6.
so that would be actually less than what the COG, because there each cycle they've used around 1.2 grams. So that's
1.2
more.
grams.
Yeah. 1 or 1.5, I don't remember, but that's what we need to check.
1.2, ma'am.
Okay, thank you.
So Venkatesh has asked regime for induction if unfit for doxorubicin. So we saw that traditionally drugs that are effective are ifosfamide, etoposide, or irinotecan temozolomide can be used in these patients because the response rate is higher compared to the traditional VAC regime. So irinotecan temozolomide can be tried, and if response, then surgery can be planned. If upfront metastatic Ewings, then what is our approach? We give 3 cycles of VAC, and if good response, then we change it to the traditional EFT 2001 one protocol, sir.
And also,
BAC,
Prabhat, I would just want to add to this, maybe things have changed, but see, it is also, as you rightly mentioned, in one of the things that when you have lung metastasis, even in that Ewings, they have treated it radically. But somebody with multiple and extensive bone metastasis, that may be a different. Uh, so, somebody with multiple bone metastasis, would we switch over to IE? That's even if they have an initial response. So that is, I think, a more difficult or situation, because those with bone metastasis have like worse outcomes, and you can update on whatever the recent.
yes, ma'am. So those who have bone metastasis, if they have good response, we continue to use EFT 2001. If there is initial response, the radiation guides give to most of the sites, at least to the primary, there no good response. If by
Prabhat, we can't hear you. I think we've lost your audio.
for the trial that VAC is superior to VAC, but in EFT we use. So there are 2 sets of regimen which are being used. One in Euro Ewings, always VAC, ifosfamide and doxorubicin, all 4 are combined. And in other set of in America, it is VAC and IE alternatively. Nobody has compared it prospectively whether giving it alternatively versus giving it together is better. Ewings is already always done it in this manner, VAID, and VAC versus alternative IE is done by the Americans. And then there is what is EFT salvage protocol. EFT salvage protocol is based on the active drugs, as I showed in my recurrent slide. those whatever were active drug, they were combined to form the EFT salvage protocol. I'm not sure if there is any prospective evidence of using what is we called as EFT salvage protocol. And then Lingraj has written that Ewings to 2012 is doing this comparison of what Akhil had asked.
Thank you, Dr. Prabhat.